My name is Linda Waldman, and I've been working in the area of environmental health for several years now. And what I'd like to do today is share some of this with you. My lecture is divided into 3 parts. In part 1, I am going to provide an outline of environmental health, looking at the approach, emphasizing its key components, and exploring the precautionary principle. In part 2, I explore a sub-theme of environmental health, looking at asbestos as an occupational health case study. This section broadens out the perspective to include socio-economic, political, and personal perspectives. In part 3, I examine social movements and the democratizing of health. This involves another case study, one on the breast cancer movement, and an exploration of how different kinds of knowledge shape understandings of environmental health issues. Part 1, what is environmental health? Environmental health really started with the publication of The Silent Spring, written by Rachel Carson in 1962. This book created an awareness of the environment and its state of health. It was the first environmental intervention, and it led to activists and the creation of the environmental movement, which we will hear more about in part 3 of this lecture. Carson spoke about the unintended consequences of good intentions, about the effects of DDT or pesticides on the food chain, and she argued that humans have a responsibility to understand the unacknowledged conditions of the environment and to be mindful of the consequences of what we do. She asked, who has the responsibility for what is lost from the environment? And out of this work emerged much stricter environmental controls around pesticides. Environmental health recognizes health as being comprised of 3 essential components, and you can see this on the diagram on the screen: the host, the environment, and the agent, or, as it is more commonly known, the epidemiological triad. The host is the person who is ill and who is affected by a wide range of things, including race, age, sex, and genetic profile, religion, previous illness, and so forth. Environment refers to the natural environment, such as the temperature, humidity, as well as to the constructed environment, housing arrangements, the neighborhood you live in, the food you eat, and other external or negative effects, such as radiation, pollution, toxicity, noise, etc. The agent refers directly to what might be affecting the person. This can be biological, in the form of bacteria or viruses, or chemical, poison, smoke, alcohol, or physical, such as trauma or fire. Environmental health focuses on topics such as toxicity, exposure, dose and response, individual susceptibility, risks and benefits, environmental justice, community resources, and action. By focusing on these many topics, environmental health offers a holistic conceptualization of health, which challenges conventional approaches to medicine, particularly those put forward by governments, industries and business, and insurance companies. For the most part, biomedicine emphasizes scientific and technical ways of knowing, in which the physician has access to expert knowledge and authority. Sick bodies are based on pathogenesis, and treatment is based on complex relationships between pharmacology and healing. For the most part, biomedicine emphasizes scientific and technical ways of knowing, in which the physician has access to expert knowledge and authority. Sick bodies are based on pathogenesis, and treatment is based on complex relationships between pharmacology and healing. In environmental health, we see people appropriating the symbols and knowledge of biomedicine, so that expert knowledge is no longer the preserve of the physicians. We also see the introduction of other ways of knowing, such as lay knowledge and experience, as alternative forms of rationality. And you'll hear more about this in part 3. In environmental health, the source of the problem is often located outside of people's bodies, and other reference points are brought to bear beyond the expert knowledge of diseases, such as questions of social justice and environmental degradation. Moving on now to the precautionary principle. This was endorsed in 1982 when the World Charter for Nature was adopted by the United Nations General Assembly. The precautionary principle is a foresight principle which aims to protect health and the environment in the face of risk. The idea is that when an activity raises threats of harm to human health or to the environment, precautionary measures should be taken, even if some cause and effect relationships are not fully established scientifically. The precautionary principle has 4 basic components. First, to take preventative action in the face of uncertainty, rather than waiting for something to go wrong and then trying to amend it. Second, to shift the burden of proof onto the proponents of an activity. In practice, this often happens the other way, so that people who resist an activity are left trying to prove that it is problematic, rather than those who are implementing the activity proving that it is not problematic. The third component of the precautionary principle is to explore a wide range of alternatives. And lastly, it involves increasing public participation in decision-making. As a result of having the precautionary principle, one often hears that it is not necessary to worry about health or the environment, for instance, when introducing a new product. But in practice, it needs a very high degree of certainty before preventative action is taken, and so we often assume that something is safe without really being sure that it is. Critiques of the precautionary principle also commonly state that it is not scientifically sound, that current regulation is itself precautionary, and therefore we don't need to worry about additional precautions, and that the principle inhibits innovation. In practice, the emphasis is on the management of risk rather than prevention. So environmental health becomes weighted in favor of remedial practices rather than prevention, and we'll see more of this in part 2 of the lecture. The precautionary principle is often not used as intended, and often becomes dominated by managerial processes, which emphasize selective elements of the epidemiological triad. For instance, it is possible to just focus on the agent and the host. You can emphasize only the factory workspace as an area of concern, and this allows one to quote-unquote protect workers while ignoring the broader context or the environment in which they live. Bennett refers to this as an imaginary jurisdictional fence. Or you can rotate workers so that you can constantly change who is being exposed. This is often referred to as quote-unquote medical removal. In environmental health, a lot of emphasis is placed on regulation and policy. However, the focus of these policy measures is often on visible pollution, automobile fumes, smog, landfill, raw sewage, and you can think of other examples. These issues are often very place-specific, they're very obvious, and the cause and effect are closely correlated, so it's very easy to identify them as problems. There are often places in which natural, technological, and social hazards are combined into what Selecki terms a dynamic hazardscape. But Casperson and Casperson draw our attention to what they call hidden hazards, things like acid rain, asbestos, the Sahel famine. They ask, how is it that given all the ongoing attention to risks in the media, that certain risks manage to pass unnoticed or unattended, and they grow in size until they've taken a serious toll on human health or on the environment? And their answer lies in two aspects of concealment. Hidden hazards, they argue, are partly hazards that are easily concealed. They do not have a strong, visible, physical presence, and partly in the nature of society, which exploits the product. So societal values, desires, politics and economics facilitate concealment in particular ways. Those at the margins of a society are often most affected by these elusive toxic hazards, which remain concealed from those at the center or in the mainstream. Those at the margins also experience what Smith and Izzati term risk overlap. In other words, they are exposed to multiple and different risks simultaneously. So, this is part 1 of my lecture. But before going on to part 2, which looks at an occupational health case study, I would like to ask you what you think are the hidden hazards